So without further ado, I'd like to introduce David Guy, who's the Strategic Health Broking Lead at Aon, and he's going to be doing a session for us on the use of data to anticipate health risks. Thanks very much, David.
Thanks, Dawn. Welcome, everybody. Good morning. Before I make a start, I just wanted to give an anecdote. And in the true theme of these types of events, the anecdote will be very loosely connected to the main theme of the day. But the anecdote's around data, and we're here to talk around data, how we can use data to anticipate health risks, understand health risks in the workplace, and make better decisions. And the anecdote I wanted to give is from 1814. So I've intentionally picked a date that I thought not many people will have a clue what I'm talking about, so I can probably elaborate a bit on the story. But it's 1814, and it's the Great London Beer Flood of 1814. And the backdrop to that is a young man took on the business from his father and wanted to emulate his dad. And he wanted to build a huge wooden cask to store lots of beer for the London people who like drinking beer. And he used a couple of data points. See, this is the tenuous link. He used a few data points. He knew that people in London like drinking a lot of beer, and he knew he had a lot of wood to build a big oak cask. So he built this big oak cask and filled it with water. But he crucially missed the third data point, which is how much pressure a wooden oak cask can take. And as a result, the wooden oak cask exploded and flooded London with 4-foot waves of beer. There is a slightly darker end to the story, which I will stop there. But the reason I mention that is the importance of using data has been consistent throughout history, for many reasons, and it's no less relevant now around health risks. To get to the real point, and to frame this in context, I wanted to use two relevant data points. And the first is from Aon's recent Global Risk Management Survey. And this is a survey that is answered by risk managers and finance people. So not the traditional audience from a people conversation. But they rated the number 2 risk, current and future risk in their workforce, was the failure to attract and retain talent. That is the first time in the history of those surveys Aon have completed that a people risk was in the top 10 and it came straight in at number 2. A business risk is the failure to attract and retain talent. At number 3 was the challenge of recovery from economic slowdown. And if you go one level below, it's to do with productivity, it's to do with people productivity. So I want you to remember, risk people, finance people are saying attraction and retention is important, and productivity of our people is important. So that's one data point. The second one is our recent employee sentiment survey, where 4 out of 5 demographics, so from baby boomers all the way through to Gen Z, 4 out of 5 demographics cited access to medical benefits as the number 1 thing they receive from their employer. Why is that relevant? What's the context behind that? We're also seeing and increasingly hearing from clients that we speak to that cost optimization is a big driver in the business. We've just arguably are coming out of a semi-recessionary environment, and we know cost containment is more important than ever. So on the left-hand side of that is a seesaw, in case anyone hadn't picked up on that. That is a very graphically designed seesaw with a little triangle in the middle. On the one hand, we've got businesses saying we want to attract and retain people, and productivity is important, whilst at the same time saying cost containment is important. We can't spend more, we need to manage what we spend. But on the other side of the seesaw, we've got employees saying we want more. I know I certainly say I want more from my employer. People increasingly want access to medical benefits. And when we're focusing around people risk today, we're going to use the theme of medical for a number of good reasons, one of which being it's very relevant and it's in the news a lot at the moment. So there's an immediate challenge with balancing that seesaw. Data is the key to understanding and getting that balance right. To put this into the context of the UK, we're going to do a very high-tech poll of higher or lower people raising hands. So the question I want to pose is how many cases were there on the NHS waiting list as of February 2025? Higher or lower? Hands up if you think it was higher than 7 million. So one, okay, hands up if you think it was lower. 1, fantastic. I'm very sorry, I've seen the answer. You are the pessimist that I like, but everyone else was correct. Slightly leading question, of course it's higher. 7.4 million people, as of February, were on an NHS waiting list. That's 9%, 9 and a bit percent of the entire UK population was on an NHS waiting list. As of February, the wait time to see a consultant, once you'd seen a GP, was 14 weeks. And perhaps the most depressing, the saddest fact of all, is the NHS have not hit their own self-set cancer targets since 2004. So that's the diagnosis and the ongoing treatment of cancer. So 1 in 10 of us is potentially on a waiting list, and I certainly do. We probably all know someone who's been in that cancer statistic in the last couple of years. Why is that relevant? Well, that has a direct impact on the workforce. You will have people in your business who are sat in this data. You will have people who are unwell and unable to access care. From a people perspective, that's not fantastic. From a business perspective, that impacts productivity. You might have people who are absent and not productive, or you might have people in the workplace who are unable to access care for them or their family. But bringing this down a bit closer, what's the real impact of that in the context of benefits and health in the workplace? These are the claims rates for private medical across Aon's book of business for the last few years. And what we're looking at is along the bottom, the months of the year, and up the left-hand side, the number of claims in any one given month. And we've got the red bar is 2022, all the way through to the latest grey bar. If you can see at the back, if you can't, it's very high, the grey bar in 2025. And what's this data telling us? It's telling us clearly more and more people are accessing private medical insurance. More and more people are claiming. People are claiming because they can't claim through the NHS or they can't access care through the NHS, but also the prevalence of things like digital GPs. Quick show of hands, who's got access to a digital GP? Who's used it in the last year? Only a couple of hands went down. I know I've used it a few times. Digital GPs only referring to the private sector. So it's a vicious cycle. It's a great benefit to have. I think pretty much everyone's hand went up. It's only making these numbers worse. But the question is this a bad thing? If your organisation offers private medical insurance and people are using it, it means they're not stuck in that 7.4 million. If you don't offer it or people aren't using it, they are. So immediately there becomes a balance between that employee sentiment survey, people want access to this, but the business wanting to contain costs. But what's the impact? What's the so what? More people are claiming on private medical insurance. More people are sick. From a business perspective, so what? What's the impact? The impact is cost. What we're looking at is the average renewal increase from the holding insurer across Aon's portfolio for the last 5 years. We've got the percentage up the left-hand side, and you can see it above the bar as well. Now, these increases are compounded. There are clients that have had, and we know them, we have clients who have had year on year, roughly an 18% increase in 23, a 32% increase on top of that last year, and we'll be getting in or around a 24% increase this year. You can see a couple of faces, a couple of heads nodding then. It's a real risk. So it reinforces people want access to this, I want access to it. Employees want to use and access care and benefits that provide care, but businesses are paying significantly more to provide it. There are 3 main drivers for this. Number 1, more people accessing private medical insurance. So despite these increases, we see membership of private medical schemes increasing. People either electing to join company-sponsored benefits, private medical schemes, or companies opening up membership despite the big increases. People are asking for it. So we've got more people joining private medical schemes. Number 2, we have more people claiming. More of those people are claiming. We hear some insurers cite in excess of 100% increase in utilisation of private medical schemes in the last 12 to 18 months. So more people joining, more people claiming. And the third one, more expensive treatment. We touched on briefly the NHS struggling with their cancer commitment. Just over 40% of cancer diagnoses through the NHS are stage 3 and stage 4. Later stage cancer is more expensive to treat. Also, in some cases, takes longer to treat. One of the few things that didn't slow down during COVID was trials and tests on new cancer drugs. So there's a lot of medication available there in the market, but comes at a price. Comes at an incredible price in some cases, and some insurers are looking at which drugs they will fund because of the impact that could have on the sustainability of premiums. It's at this point I realise I should have caveated at the beginning, this does take quite a sad dip in the middle, so apologies for that. But there are three strategies, I love my threes, there are three strategies we can deploy to help manage and get on top of this as businesses. The first one, good old traditional broking. I would say that I'm from Aon, but good old traditional broking. How can we take our policy to the market and negotiate to get a better price, either with your existing provider or somebody else? We'll have a look at a second of what the impact of that is. But number two, you can look at design. How can you structure your benefits so they are aligned to your peers, aligned to the market, or are helping to contain costs? Now, there's a real moral issue with that. What's the purpose of providing benefits? Is it for people to use? Is it to attract people? If people are using benefits to manage their health, stopping people or restricting people from accessing it is a bit counterintuitive, but in some cases necessary. The third one is performance. And to manage performance, we need to understand the data. We know from our data that broking does work to an extent, and the grey bar is the average final price once you've tested your scheme against the market. And one thing you'll notice is the gap between the red and the grey is getting smaller and smaller. And the grey is higher than the red was a few years ago. So we know broking works, but we know it's not sustainable. We know that you'll come back a year, 2 years later, and you will still have people risks. You will still have those drivers for claims. Benefit design can range from drastic to not so drastic. You could add a couple of percent, you could add more. But again, what's the impact on people using the benefit if it's too expensive to use? So performance. How can we use data to understand how schemes are performing to get ahead of those risks to do something about it? Quick show of hands again. Who uses data in the workplace to help drive their decision making? Okay, most hands up. Who uses as much data as they would like? Tentative. We'll go with a yes. Yeah, okay, there was one or two there using data as much as you would like. It's quite resounding. Everyone put their hand up for a yes, we use data. 2 people tentatively put their hands up saying we use it as much as we would like. If we think of this in the context of benefits and healthcare and the other things that you offer as an organisation, there's a lot of data out there. You'll have group life data looking like this, telling you one thing. You'll have medical data reporting on different data points. You'll have OH data, absence data, and none of them correlate. They all report on different things. They all tell you different things. Well, what if you could start consolidating that data and bringing it all together to tell a more connected, joined-up story? Well, you can use that data brought together into one place to start spotting trends, to start looking at what is the true risk of my workforce. You could start using those data points and those trends to predict what future cost might look like. You can use that data to help prioritise the policies, the benefits, the things you offer that are driving your cost, and perhaps where you should focus more. You can then start overlaying health data on top of it and demographic data. What does your workforce look like? And this graph is telling us the ages of this example, the individual ages along the bottom, and the number of people in that age group up the left-hand side. We've got females in green and males in red. Sorry, the other way around, females in red, males in green. So you can start overlaying what are the health risks that we know affect those different demographics. Now, all of a sudden, you've brought all those data points together, you can start focusing even more on where does my health risk sit? What demographics are driving my risk today? But looking ahead, what's my demographic going to look like in the next few years? So already you can start to use those collected data points to narrow down your focus. But you can go one step further and start looking at where does my risk sit against my known health risks, or perhaps my unknown health risks? You can start looking at across your benefits, your policies, things you have in place to help people risk. What's my claims incidence? How many people are claiming? What are those claims costing me? And you can start benchmarking that. How do you know you have a people risk? How are you comparing that to other people? Bringing those data sets together, comparing it against a big book of data, helps you to start benchmarking where your risk sits against your market, your peers, your competitors. But crucially, it gives you three strategies, another three, gives you three strategies. If you are looking at design, it gives you an idea on where to start looking. There's a laser on here, I was amazed by that. You might think, well, actually, my cancer is way out of control. I've got huge cancer risk across all my benefits, across all my lines, or perhaps only in certain areas. Should that be making that sound? Stopped, okay. If you're going to focus in 2 or 3 areas of design, this will help you. Bringing those data sets together will help you know where to focus. You could start looking at interventions and knowing which areas, which health risks you need to focus your interventions on. It can also help you start looking at preventions. What benefits and policies do you have or not have in place that can prevent people showing up in these data points in the first place? But what happens if you've got lots of data? What happens if your data is incredibly complex? What happens if you've got to make very complex, difficult decisions that have a huge premium huge revenue or huge premium attached to them? What happens when you're getting the tap on your finance people in your business asking, why is cost going up? How can we manage that? Last show of hands, I promise. Last show of hands. Hands up if you use an AI tool in the workplace. Okay, most hands. How many people are using it to help manage risk? Okay, 1, 2, 3. Okay, only a couple. The talk from Dr. Helen Fry this morning touched on AI and how we're only using the tip, or at the tip of the iceberg of using technology. But what if you can start using AI to help you navigate all those vast sets of data, to help you make sense of very complex data points that would take humans an awful long time to? And I've tried to do it, and I couldn't make head and tail of these big data sets. AI is a tool that can help you with the decision making when data is complex, decisions are important, and decisions are impactful. I think my weight is setting off, so I'm not going to stand there again. I'm probably in this data somewhere. You can use AI to start modelling your health risks in your business. You can use AI to start looking at where are my claims today on my medical scheme? Who in my workforce is low risk? Who in my workforce is an emerging risk? And you can use AI to model your data sets against millions and millions of lines of data to predict 12 months forward who's going to be high risk. How many of my population are going to be claiming for high risk or high volume conditions in 12 months' time? You can then start using data to look at the demographic risks. Where are my people on a risk matrix of high value cost claims, so cancer, versus low cost but high volume claims such as MSK? Which demographics in my workforce is AI telling me, machine modeling telling me, with a high degree of certainty will be a claimant in 12 months' time, and what's the price point? What are my people going to be costing me from poor health risks in 12 months' time? So we can use AI and machine modeling to start plotting out what are the health risks of the future that are impacting my workforce, so I can make better decisions today to prevent those health risks from occurring. But how do we do that? We've got the data. We know the future might not be pretty. We know we've got health risks coming up. We can get ahead of it. We could see around corners. But how can we start managing these health risks? Well, then you can start looking at what you offer. What are my services, provisions, benefits that I have in place as a workforce that I can better deploy to start targeting, effective targeting against demographics that are driving risk? So, for example, you might have, your data might tell you you have a population of males 40 to 50 who are extremely high risk of cardiovascular claims in 12 months' time. What do you do about that? Well, if you've got a communications platform or a communication strategy, you can start pointing your communications at that demographic, and you can start pointing them towards things like health screening. You might think we have a mental health risk. Actually, musculoskeletal might be the big risk in your workforce. You could start using targeted communications and benefit platforms and the benefits you provide as a business to help target those individuals who are driving your high-risk claims. So just before we finish, 3 things to remember, 3 things to pull out from what we've talked through around data and understanding data and using data to help anticipate health risks and drive better decisions. First of all, how are you using data to understand where your costs are lying in the future? How are you using data to anticipate your premium renewals on your policies in 12, 18, 24 months' time? What visibility do you have as an organisation? Number 2, how are you as an organisation using your data sets, data you have available, to understand and anticipate health risks and the cost drivers for those health risks? And finally, what are you doing now to manage those health risks of the future, to not only improve health risk, improve performance and manage costs, but also drive the employee value proposition of your employees? How are you helping them access the care and support they probably don't know that they need, but receiving it will improve their perception and their value of the business? I will stop there. And if there's any questions, if you've sent... Thank you. If there's any questions through Slido, I think if anyone has a question and they'd like to put their hand up.
Brilliant. Well, we've had a few questions come in, David, so thank you very much for that. I suppose the top question in terms of what we always get asked is, where do you get your data from and is it credible?
Yes, it's credible. I have to say that. It is credible. There's a few different data points within there. The most recent one, the modelling of health risks, that comes from the Aon portfolio of data. So we've got a vast book of data, access from a medical perspective especially, access to millions and millions of lines of data from the likes of Aviva, the likes of Bupa, the likes of AXA. So we can model, we've got enough data to confidently and competently model individual company health risks against a huge reservoir of risk data. I think the other data point was pricing trends. Similar, we use our portfolio of data, all the market reviews that we complete annually. We store all that data centrally to give our clients an understanding of what pricing will look like in the future.
Fab. So how do you ensure that companies use the data ethically and not manage out high-risk individuals to reduce medical costs?
Yeah, OK. This is a question we get asked a lot. There is a big difference in the analytics tools between the UK and broadly Europe versus the US. In the US, those data points are individual. So in the US, they can pinpoint individual health risks. In the UK and Europe, because of GDPR, and for very good reason, it's a demographic risk. So you need to have, and I can't remember the exact number, but you need to have enough people in a cohort, a demographic cohort, to be able to drive those risks, to the point where it's the GDPR is satisfied, you can't identify an individual.
OK, fab. So in terms of, we also just touched on prevention and different interventions that you could do as a result of the data. Can you also test what those interventions might achieve?
Yeah, absolutely. The key to that is data. So finding the intervention, identifying the intervention is led by understanding your people risk, understanding the interventions that will have an impact. And you can use the data to model the impact. So, for example, if you were addressing, I use the cardiovascular example, if screening was the appropriate solution, you can use data to understand how many people are accessing health screening. If we're targeting males 50 plus, how many males 50 plus are accessing the health screening? But then you can refresh the data and look at what's happening with my claims history. Am I seeing a drop in cardiovascular claims across all my benefit lines, across my absence data? And if you are, it's working. But accessing the data is important, because if it's not working, you need to come up with a new strategy. And again, we can use the data to help anticipate and understand how that's progressing and the success it's having.
So I suppose you could potentially look at it and go, yes, I'm going to introduce health screening, or no, I won't, because it's not going to have an impact. Or would it work like that, in that way, in terms of understanding whether the intervention will have a desired impact that you want?
Yeah, I had a conversation with a large high street bank recently, and we were taking them through the data story, and they were saying, well, we need help to increase health screening utilisation. And the question back to them was, well, why do you want to increase health screening utilisation? We want people to be screened. Why do you want people to be screened? What's your data telling you? If you've got people with a huge mental health risk, health screening is probably not the right thing to be focusing on. So again, understanding those data points, understanding where your risks lie, and then mapping the appropriate solutions that you may already have. You may not be utilised as much as you want, but mapping those solutions to the known health risk, and then measuring the impact of that through claims, the impact of that through utilisation, will help you understand what solutions are right for your people risks.
Brilliant. Well, thank you very much, David. I think that's all we've got time for this morning in this first session. If you could please remember to rate the session in Slido, that would be very, very much appreciated. We've got a short changeover now. I think it's sort of 5-10 minutes. So thank you very much, David.
Thank you. Thank you.